So scaphoid non-unions have been classified by Slade and Dodds, and then modified. The classification of non-unions modified by Tim Herbert. And basically, the types of non-unions can be either stable or unstable. I'm a simplistic kind of person. I like to think in simple terms. So they're either stable non-unions or non-stable non-unions. If the length of the scaphoid appears to be preserved on radiographs, then there's a greater possibility it's going to be a stable non-union. If there's angulation or shortening of the profile of the scaphoid on plain radiographs, and there's a greater chance it's going to be an unstable non-union. CT scan is the best way of evaluating in detail the fracture gap or angulation of a scaphoid fracture or non-union made in 1 millimeter cuts, and preferably in the plane of the scaphoid. The MRI scan is best for evaluating the viability of the proximal pole. And we'll say a lot more about the circulation, which Dr. Osterman already not just alluded to, but spent some good deal of time. And I should think that it's a lot more important consideration in non-unions than you may his initial presentation. In a nutshell, pain and tenderness over the snuff box after 12 weeks is a non-union until proven otherwise. The treatment options for scaphoid non-unions are either non-operative or operative. Non-operative requires further immobilization for an additional 12 weeks minimum, and you may want to consider adding the potential advantage of electromagnetic stimulation through a coil outside the cast. A trick to this is considering adding an iliac crest bone slurry to the non-union site. And you obtain this with aspiration under local anesthesia of bone marrow from the iliac crest using a 16-gauge needle. Either centrifuge it or strain it and then inject it back into the non-union site with an 18-gauge needle and under fluoroscopic guidance. And in my experience, we get greater than 90% union rate of confirmed non-unions by 8 weeks after this technique. The operative treatment involves a corticocancellous inlay graft designed by Russe or Fisk. The more proximal the fracture, the greater the chance of it developing avascular necrosis. And so consideration of a vascularized graft, corticocancellous graft, is worthy. Christoph Methuen has written this up and described it very extensively with a graft from the distal radius, or you can use a free vascularized graft from either the femur or the iliac crest, either one giving you about an 80 to 90% union rate. This may be a tip, it may not be, but you can consider using BMP, bone morphogenic protein, or PRP, injected into the fracture site instead of a vascularized graft. This certainly avoids the surgical technical challenge of a vascularized graft, but it is less, it has a less predictable union rate, possibly because we don't know as well about what we're doing. Internal fixation can be added to scaphoid non-unions, and for this, it's recommended a headless compression screw, either a Herbert screw, or Herbert Whipple screw, which is cannulated, or an Accutrack screw. And then MedArtis has devised a tri-lock plate in 2 sizes, but this is a very, very challenging a reduction and fixation device owing to the fact that 70% of the bone is covered with articular cartilage. Here's a very good tip. You modify the Russe corticocancellous graft into a strut inlay graft, as you see illustrated in the bottom left illustration, plus the axial screw. This provides better rotational stability than the Russe wedge graft illustrated on the right inferior illustration. And you can read more about the techniques of this strut inlay graft from Amy Ladd in the 2020 Journal of Hand Surgery. Arthroscopic approaches to scaphoid non-unions are possible. You can reduce unstable fractures, but it's easiest to start this technique with stable fractures primarily. An important tip is to use the Linvatec traction tower. Yes, there are many other types of traction that can be used, but this is the only tower that permits both traction plus extension plus ulnar deviation of the wrist, so you can gain access to the scaphoid. Very important to visualize the scaphoid fracture from both the radial midcarpal portal in the midcarpal space and the 3-4 portals in the radiocarpal space. And the technique for debriding and bone grafting is best described by P.C. Ho from Hong Kong, who has a wonderful technique for the bone grafting. Here's a trick for internal fixation combined with graft fixation arthroscopically, and that is to add a cannulated variably pitched screw to the fixation device. The advantage of the screw coming from distal to proximal approach from the volar side is that you can access more of the distal pole of the scaphoid by amputating the tubercle of the trapezium and have a better chance of passing a K-wire than a Herbert screw down the central axis of the scaphoid bone. There are impediments to the volar approach. It's true that fractures in the proximal third of the scaphoid go to avascular necrosis in about 30% of the cases, and in the proximal fifth of the scaphoid, you get 100% avascular necrosis. So Slade correctly indicated that the dorsal approach provides a better chance of axial screw displacement, but there is still a risk of multiple attempts to hit the central axis, beating up the precious articular cartilage on the proximal pole of the scaphoid. The late J. Rue and I designed a scaphoid fracture reduction and fixation jig in 2017 that helps to reduce the humpback deformity and reduce the trauma to the proximal pole with just one shot for pin placement to hit the central axis on virtually every attempt, and with the screw then to compress the graft and the scaphoid fragments. ORIF may actually lead to scaphoid non-union. The axial screw fixation is popular, but the problem is that without adequate compression of the fragments and or the graft, these fragments may rotate about the axis of the screw, and rotational instability leads to non-union in a large percentage of the cases, as Geyer illustrated in the Journal of Hand Surgery earlier this year. A trick to avoiding this is using two parallel screw fixation instead of just a single axial screw. And this technique has been popularized by Bobby Chabra at the University of Virginia. And a second trick is to modify the reduction fixation guide from Rue so that you can place two parallel pins in the axis of the scaphoid to get the two parallel headless screws installed. Leave you with this slide that shows the importance of the circulation, the retrograde circulation inside the bone. And you can see on the left portion of this illustration, the more proximal the fracture, the greater chance of establishing a non-union. Thank you.